Good afternoon, everyone. Oh, we got to do better than that. Because I'm the last thing that stands between you, the poster presentation awards, and dinner, and my workout, which I haven't had. So let's try that again. Good afternoon, everyone. All right. We need to have some energy. I know it's late and it's a dreary day here in Baltimore. So thanks for having me. So we'll go ahead and get started with the presentation. I do want to thank the conference conveners for having me here, but I do want to give this disclaimer for those of you that are online and those of you in the room, because oftentimes what I've found is when you have multiple affiliations, people will pick what they want to choose, right? It's like scripture. You choose what fits the scenario. So I'm telling you that anything that I say has nothing to do with any of the affiliations that I have, whether that is Rutgers, whether that formerly was NSF, or whether that's NC State. All right. So let's get started. So this is a sort of a schematic of what generative AI does. And I know that everyone in here realizes that. But one of the things I want to point out about generative AI is that this need that we have for right at the beginning, large sets of data that could be text, that could be image, that could be audio, that could be video. So anything that we are, you are, industry is producing is going into the model so that we can learn. And what was interesting, I think, on the panel, I think it was actually the undergraduate student, I don't see him in here, that mentioned that all of your queries, you're actually helping to train. So just a show of hands, how many Copilot users do we have? Wow, ChatGPT, Perplexity, Gemini, all of the above. Yeah. So use it for different things and it comes out and it synthesizes data. So what is interesting here is that, and I'm going to be giving also a context like my colleague from this morning. I think we're going to use healthcare as a use case because a lot of my research is in healthcare. So I want to start out with this, and this is what Harvard School of Public Health stated, that 50% is the projected projection in treatment costs just by using AI for diagnoses. For diagnoses, it has nothing to do with treatment in that 50%. That 40% is the projected savings to improve healthcare outcomes using AI. And then look at what Statica says is the marketplace. $187.9 billion is the estimated market in AI in healthcare by 2023 or 2030. So are there any doc students in here? Yeah, sure. It's okay. You can raise your hand high. I remember Howard University. I remember what you said when you were on the panel. Who else? Any doc students? Any postdocs? Postdocs. Let me tell you what I didn't hear today. What I didn't hear is I heard a lot about AI development. I heard a lot about AI interrogation. I heard a lot about AI use. I didn't hear anything about innovation. So, postdocs, doc students, innovation, right? Where is the development? Where does it mean? Do you understand the marketplace? Where are you innovating? Not necessarily being a user, not a consumer. So, applications for generative AI in healthcare. This is sort of a schematic that consultants have written up. And where are the potentials for healthcare? And you'll see right off the bat is generating and synthesizing the data, advancing drug discovery for disease conditions, enhancing medical diagnoses, managing clinical documents. How many of you use my chart? Epic loves you, right? Yeah. Documenting clinical documents or managing those clinical documents, personalized health and treatment to your personal condition, and then post-treatment monitoring. What's going on? Was the treatment effective? And then how does what has happened to you relate to population health, right? And what can we say about states, cities, municipalities, groups of people, types of diseases? So in terms of impacting patient and the healthcare professional experience, the diagnoses, what we found is that, and what has been reported, that AI can analyze, of course, large sets of data to help docs make faster and more accurate diagnoses. How many of you have been to the doc in the last 30 days? 60 days, 45 days, 6 months, 1 year? Everybody's hand should go up at the 1 year point, okay? The 1 year point. So that diagnoses of whether that's faster or making more accurate diagnoses of whatever the issue may be, even if it's saying, check, good health, go on, see you next year. Treatments, providing protocols for personalized health. That means my health conditions, we might have the same disease conditions, but it may manifest itself very differently. You hear this a lot, right? Heart health in women, the symptoms are very different than heart health in men, right? So what is that? For example, using genomic and clinical data, and then the idea that patient care. I think it was Jay, I don't see her in here, but Jay gave the example on the panel about how data were being collected in community by community, almost like a citizen science. She didn't use that word, but that's what it is. It's a citizen science approach. And here, patients actually being actively involved in the clinical care process. Disease prevention, and that is to promote, listen at this, online and analyze social media text. Where's my large language processing, natural language processing? Someone was doing that. Yes, yes, natural language processing. How do you describe disease on social media may be very different than what you describe in the doctor's office, right? And then resource management to help health professionals manage their resources more effectively. The last point on this one, and I cannot underscore this enough, that all of the situations above, all of the practices above, what does the electronic health record say? And does it capture what the patient actually experiences? Or is it a group of diagnostic codes and IC codes that are used? So in a lot of ways, the electronic health record is to be longitudinal. So you can watch me, and what we call, there is actually a disease, a health state or health span, and then there is a lifespan. Do we capture lifespan of an individual, of me, from infancy until adulthood? If you have not seen this, the National Institute of Healthcare Management, which is in DC, does some really great work around healthcare. And a few years ago, I was involved with them and a gentleman by the name of David Jones out of the Harvard Medical School, where we took a look at what are algorithms and how are they used in clinical care practice. So I'm going to start on my right, which is your left, where it says cardiology, nephrology, and obstetrics. This is an infographic that you can still go online and you can find. But if you take a look at what happens in disease conditions, AI is actually being used in cardiology. In cardiology, you get what is called a risk score. that will categorize patients to determine what his or her or they risks are. What has been found is that that use has been oftentimes categorized and used inappropriately. And what does that mean? That means sometimes that the impact of that use in clinical care may raise the threshold or resources or clinical resources for particularly for Black patients. I didn't say that. Let me go online. Everybody online. I didn't say that. This is what the clinical care team has actually found out. In terms of nephrology, your kidneys, the EGFR and a number of other equations or algorithms have been used and have shown that you actually have higher values for patients that have identified as Black, suggesting better kidney function. Why is that a problem? Well, kidney function may delay being referred if it's inappropriately and incorrectly used, may decline or delay referral to a clinical specialist, to a nephrologist. Why does that matter? There is a connection between your heart and your kidney function. Secondly, or lastly, example that we gave was actually the algorithm to use to decide whether a female would have a vaginal birth or have a cesarean. What we've learned is that it predicts a lower likelihood of success for African American and Hispanic women. Therefore, the benefits oftentimes of the vaginal delivery is precluded from those populations. Okay. What we also found is that in this algorithms, in a study of 2019, one of the algorithms found that Black patients who are considerably sicker than white patients were given the same risk score, therefore did not receive the same level of care or quality of care in those cases. I didn't say that. You can look at Oblingen's work. It was published in Science magazine. Computer scientist out of Stanford University. In so much as this is important, it says that bias does exist. Bias does exist. And that the bias were eliminated, the percentage of Black patients that would be enrolled in programs would have risen from shy of 18% to almost 47%. So you get a certain level of treatment or not, depending on at the time what the algorithm suggested. And a lot of times we say, oh, we're just excited because we've got data. Any Star Trek fans here? Yeah, Star Wars fans. So I snapped these because there's an excitement oftentimes in community when you get data. And I'm no different. I'm guilty. My colleagues and I, at the time at NC State, we were so excited about data. We got the data. We're ready to model. And what were we ready to model? We were ready to model because we had interest in HIV. We had interest in HIV and to the result that it impacts what we call length of stay in hospital and cost of the care. But we were also, and I want to point this out, and what was the impact of that on mental health? And we believe, and research has shown, that no disease exists in isolation. This morning's speaker told you that when he talked about epilepsy. Okay? Diseases do not exist in isolation. So we said, this is the data that we got. We got AHRQ data, which is the Agency for Healthcare Research and Quality. At the time, you could just download it. You hear me? I said at the time. Okay. And we were looking at outcome variables, response variables that included length of stay and said cost of care or total charges. We did 2 sample t-tests for comparisons of groups. We did GLM modeling. We wanted to see the impact of comorbid conditions on the length of stay. In other words, remember, I said mental health and HIV. I also said from the chart before, we talked about the relationship between heart disease and kidney disease. And we did GML, we did principal component analysis and cluster analysis. So we were running all kinds of models, right? We had data, we had data, we had data. I want to skip to one slide. This is what the data looked like initially. So for a 10-year period, because we wanted to look longitudinally and we wanted to follow patient X for the 10 years throughout. We got the data set. This is based on inpatient data. We had discharge records for 10 years. We had almost 48 million records. 48 million records with about 25 to 30 attributes. And we took a look and we said, can we narrow this down? This is our, what we call our selection process on the data. Because when we first got the data, we were excited. Then by the time we went through this process, we didn't have so much data. So we had to scrub. And the scrubbing process was very painful for the PhD students because they were ready to model. You could hear the fingers, ready to model. But in many cases, we had incomplete data, right? And so we looked at, in this case, and I'm just doing this one reverse order on the cases that we did, but we wanted only those persons that were above 18 years old. So we got rid of any data around children. So immediately, almost 8 million records went away, or instances went away. We had anything that was related to newborns or any procedures related to newborns. So we got rid of another nearly 4.4 million. So we already down. You following this. Then we got down to discharge over 18, but wasn't admitted. That was 35 million. Then we got down to, okay, now we have missing values. So even in the 35 million that we had, almost 7 million instances, there were missing values. Values that were improperly coded, values that were blank, values that we didn't know what they meant. There was no data dictionary. This was a mess, okay? We ended up with about 28 million, but you see all that in gray? I think the doc student from Howard said it best. We didn't go back and evaluate the missing data because there are nuggets in that. And I bring this up because for those of you looking for research, it's an excellent opportunity right there. We don't know what was in that data. We just said it doesn't fit our criteria, put it to the side. We don't know what learnings are in there. All right, so I'm gonna go back the other way. So we did that similar set for this, which was mental health, HIV. We had a principal components analysis. We could see what the loadings are in terms of, at the time, the ICD-9 codes. We found that non-dependent drug abuse, drug dependency, depressive disorder, and episodic mood disorder, those were the factors or the codes that bubbled up to have the sort of highest correlation or weight in the model with persons that were living with HIV. Now, we had no idea from the data set, what does it mean to be non-dependent abuse of drugs versus drug dependence? What we didn't learn is that physicians can make up their codes. They can decide what codes, if something doesn't fit, they can decide potentially what fits best. So randomly, what you may say, what you may say, and you may say, we may all have different, we may fit into different boxes. It's not deterministic. We also found that from the cluster analysis that there were about 8 clusters in the codes that really formed in the model. They're all in bold, from non-dependent drug abuse to drug dependency, all the way down to schizophrenic disorders. What did we learn? I'll spare you the actual formulas that we had and the charts, but what we did learn is that longer length of stay and comorbid conditions really do cling together. The HIV patient did have other diseases when it came to mental health that were present. So when you go into the doctor and you say, I'm having an issue, if you're coming in for HIV, does that mean I should discount the mental health issue that may be present or may be hard to diagnose? The mental health disorders generally resulted in decreases, which we found interesting in terms of length of stay and total charges. What is interesting in the data set is that patients with mental illnesses were more likely to be transferred to other facilities. Means they didn't stay in the hospital facility. They were transferred to another location, another treatment location, another facility, but they did not stay in that hospital. So the true length of stay, we couldn't observe it. The codes that were most popular or most prevalent in the data set, we showed those out, but what we also determined was that the healthcare delivery approaches, there is a difference between adherence and treatment. There is a difference that must be addressed, chronic diseases and their severity, particularly when it comes to comorbidities that exist. We looked at the same thing. This is the set that we looked at when it came to diabetes. We wanted to look at diabetes and how did it manifest itself. We did the same sort of analysis on this set. What we did find is that homogeneity in patients and comorbidities is rare, given that there are a variety in the demographic characteristics. There was differential treatment along with physiology and the treatment in women as opposed to men in the data set. And that disparities persisted over time when it came to women, when it came to diversity in groups of with diabetes, their outcomes are unlikely to improve when you don't account for those differences. And ethnic groups have poorer outcomes and are less likely to have routine discharges. Routine, meaning routine going to home. So how does that current research, and how was that informed, current research now informed by that prior research? So remember this in the study? In the National Healthcare Institute Management infographic, when race is excluded, what Oblimeyer said, when race is excluded, oftentimes what we do for missing variables, we use proxies. And the proxies sometimes actually exacerbate the disparity more than it does help. And so when you race blind the model, oftentimes you will get fewer resources being spent on certain populations, and the algorithm will conclude that actually Black patients in particular are healthier than equally sick white patients. This is what he found. And ideally, we have to ask, so what is missing? So like really, what is missing? And this was a quote that I took from the Washington Post. And the Washington Post said a few years ago, big data was supposed to solve and fix education, Just like in the health industry, health sector, big data was supposedly solve many of conditions, but it made the point that it didn't. It didn't. We're still here in the room talking about it. And in a large part is that it's time to recognize there is a small data paradigm. How many of you have heard the small data paradigm? Yeah, the small data paradigm. So I wrote a little piece about the small data paradigm that appeared in Scientific America. And interesting about this piece, how I came to it. I was at a conference a few years ago. I was at a conference and the speaker was talking about typical patient one. Typical patient one was a Black female, 55 years old, diabetic, who could only read at a 7th grade level. That was the context for the data set. And that this patient was non-adherent. There was treatment available to her, but she was not adherent. And because she was not adherent, she probably didn't take her insulin. And the question to me was, well, did she just not want to take her medicine? Does she really want to be sick? What's the backdrop? And that backdrop is in that small data. In that small data in healthcare, we often called some of this the social determinants of health. And so for the social determinants of health, how can in your model account for if that is the patient's actual experience? How do you account for all the things around this circle? How do you account for, yes, she may have access to treatment, but can she get to the treatment? Like, does she have transportation? Does she have a neighborhood with a pharmacy, or is she in a food desert? Is there access to care? But okay, you have access to care, but is there quality of care? That's two different things. And if there is education, is there quality education? And is this an affordability issue? Now, we all know that formularies are being, and the cost of being changed as we speak. So accounting for the social determinants of health oftentimes can help explain what the algorithm may not account for, but it may not be enough. So when it's small data and social determinants of health, space and place, right, where this person lives, but also an ecosystem thinking. A patient, a person is a whole person. They're not just a patient. Where does she work, live, play, worship? Where does she shop? And then in the set of training, the data piece, is the data that you're using actually representative? Is the data trained? Has it been validated? And what does that test set look like? And lastly, context. How can we augment AI findings and results, but also audit? How do we go back and check for the efficacy? Accounting for the lived experience. So a group of us, and I say group, so Thelma, Dr. Hurd is an MD, and myself as the compute person, and Dr. Hood is epidemiologist. We sat around having this conversation about what is and what are the needs to improve population health if we're going to use AI, if we're going to use AI, if it is going to be representative, if it is going to be responsible. And so in the piece, what we came up with was an adaptation. And remember, I asked the question earlier, are the data represented in the electronic health record? which is different than an electronic medical record. A health record, longitudinal, captures the patient all the way through. So we sort of adopted this from Lee and Kim, but put around it this idea of the social data. Everyone now, shouldn't say everyone, but a lot of us have IoT. How many people have something on their wrist? Are your rings closed? Your steps counted? You know, everybody's doing that now, right? You even, and oftentimes use them in scientific research. What is the biometrics? What's the genetic data? And what's the insurance claim data? To get a holistic picture of building what could potentially be the development of AI that will be a little more representative. And where does that data come from? We pointed out that, listen, everybody talks about the AI bias, the data bias. It's not just the data bias. There are other biases as well. I think this one is covering up the screen right here. Let me see if I can move that slightly there. Okay. All right. So we have different types of biases that need to be accounted for. And so I'm going to start with the data set one up top, which is the data bias, one that everyone knows, that talks about, is it representative? We put out here, what does that mean in a healthcare environment? The association bias, where the data are used to reinforce. The automation bias, where the automation decisions override social and cultural associations and considerations. The intersection or interaction bias, with the human interacting with AI and created bias results. And then lastly, confirmation bias, right? You oversimplify the personalization. All of these we pointed out, from the electronic health record to the cesarean example, to leveling up and designing systems for purpose and predictions. We give you all the biases and how they manifest themselves. Very important if you are going to do development, or if you're going to use data that would result in a recommendation to you. Thank you. Okay. Another example of a research study that I'm taking part in is what happens in maternal health. What happens during pregnancy? What is the birthing decision, and where is the mother's choice adopted in the decision making? So we have data that is the physiology data. We have the symptoms that are self-reported. We have nursing assessments. We have the monitor, the fetal health monitor. And usually that's it. But nowhere in there is the mother's decisions or concerns taking place. So to capture that, is that captured in that epic, in that my chart? Probably not. And so breaking that cycle, looking at all of these cases, and this is what it looks like from a software perspective. But does it account for these, what we call the FEAT model in healthcare? So if you go back, you account for all of the things that are clinical, centering the patient, the mom, listening to her. Some of you may remember what Serena Williams went through. Some of you may remember, right, what she went through and what others went through in terms of the birthing experience. Very, very common to have complex complications during the birthing process. Where is that documented? So in terms of that documentation, we want that documentation, and we want the AI to sort of follow this FEAT model. We anticipate fairness and ethics and accountability and transparency. Each of those rings on that circle, we could spend a whole day dissecting each one of those. But what is important is that there are other divides that do exist. It's not just the data and the representation, it's access to the AI tools. What is happening around workforce and training? And what does it mean to have access to computing devices when access is not enough? So when it's not enough, what we're saying here, the team that I'm working with, we're looking at, yeah, you can have health devices. You can have smart technologies. You can even have sports trackers, and you can have fun for gadgets. All of that is going to pick up data. But can the IoT pick up on the environmental issues that impact a person's experience? So if I run here in Baltimore, my run is very different, Mile High Denver. So my blood oxygen level will be different. So will my breathing pattern. So will my heart rate. Can it pick up on those environmental issues? Can it pick up on what's the quality of my air or the quality of my water? Can you pick up on food quality and transportation availability? So the question becomes, what is a true read of the numbers that we've grown to be so dependent upon, like closing our rings and counting those steps and flights? But what about genetic predisposition? And so when we're asking the question about the technologies, I put this in here because digital equity and the digital divide still remains to be a big issue. So in the state of North Carolina, I just put these statistics out here. And this actually comes from the state of North Carolina's own website. So you can see where the increase in adoption to 80%, which is the last bullet, 80% across racial subgroups, what they are in achieving digital equity in the state. It has sort of this mandate for where it would like to go in order for not just healthcare. It is saying it is an ecosystem thinking that this relates to technology access, education access, career access that drives the state economy. And so in its world, it says in North Carolina, there is a digital divide. That digital divide asks who is affected. And it says there's an attempt to close that. So it's not just race, ethnicity, because North Carolina is quite a rural state, right, my friend? Yeah. So it is rural, it is elderly. All of those things have that impact on what we now are talking about in terms of AI. Who gets to have access? Who gains access? And do they have broadband access? So the FCC has put out who has access. I just narrowed down on a certain area in the city, right? So you can see who has fixed broadband, who has mobile broadband. Does that mean that they have access or do they have use? Or is it affordable? So in this area, which is in actually downtown Raleigh, this is close to two HBCUs, Shaw University and St. Aug University. NC State is probably a mile and a half away. So inside this, the pink dots or the purple dots would suggest these are homes and places that actually have broadband access. Can we figure out how well do they have access to healthcare and education? And what does it matter in terms of development of the algorithm? Because it's not just, again, these are comorbid situations. And so the observations, opportunities, and the shortcomings is reliant on The algorithms are relying upon the data and the rules that are often generating patterns. And there's a challenge. And the challenge is that most time the algorithm, because there's some uncertainty, they're non-deterministic in nature, which means that repeatability and generalizability oftentimes is difficult to reach. And sometimes they give you recommendations. You know it. How many Amazon users in here? Yeah. One person did like this. I just asked, okay, wherever you order.com, everybody, it's somebody, right? So then you order, and then it comes back and it gives you recommendations and said, people like you also ordered this, right? That's the recommendation. Do you have to take that recommendation? No. So the recommendation, defining it, it may be a recommendation, but it's not a useful recommendation. Same thing with algorithms in healthcare and in other places. And oftentimes you'll hear, we need a human in the loop, right? You need a human in the loop because it's a recommendation. You know, I said that recently at a conference, and this woman came up to me and I couldn't agree with her more. She said, you know, sometimes it's the not necessarily human, but what kind of human, right? What kind of human? And I said, I get it, Doc. I get it, right? So it's not just the human in the loop, but it's also the human in the interaction. And the accounting of hallucination. Algorithms will hallucinate and hallucinate for a number of reasons. Hallucinate because of poor data, garbage in, garbage out. You may get the actual hallucination, which causes what is now being called what? Artificial generated intelligence. Scary, scary, very scary. But hallucinations that in a situation like healthcare could have dire consequences. And knowing, you know, I would always tell my students, and when we collaborate with industry partners, the student, and like many of us, you need to know your domain. You need interdisciplinary teams, but you definitely need someone that knows the domain. So when I'm working in healthcare, that's why a Dr. Hurd or a Dr. Hood is very important, because while I know some, I don't know all. And so your recommendation, while it may be salient in and of itself, in the domain, it may not be relevant. It may not prove appropriate. So understanding that will be really important as we're thinking about the challenges, the opportunities, and the observations associated with AI. And with that, I'll open it up and pass it back to you.
All right, we have time for a few questions. Gonna get my steps in here with the questions.
Thanks. Great presentation. Thank you. My name is Antoine Wallace. From an equity standpoint, when you looked at the administrative data set that you were using, I'm wondering if you had considered using MMS data around Medicaid and Medicare data that would give you the questions about resources that are separate and apart from private access healthcare, and would be able to be more generalizable to folks who are outside of single payer systems.
Yeah, we did, right? We did think about that. We did look at those data sets. Mapping that for a 10-year time horizon was very difficult. And I think this is part of this. Sure, we could use that. Great question. But I think the challenge is how integrative are the data sets? And I think that's the challenge that we had faced. And we had doc students that needed to hurry up and, you know, yeah. But yeah, we did think about that. And I do think that's an excellent way to get to that perspective. Our hope, And the reason why we chose the data set that we did is that we were hoping to be able to follow you or me through the data set for 10 years. And oftentimes it's not possible. Yeah. But thank you.
Any other questions?
Following on the same question, same threads of the question on data, and Google has a paper called "Everyone Wants to Do the Model Work, Not the Data Work," and it basically talks about everyone is not paying too much attention to the data and just want to grab what data is out there, trying to do the work. But the question comes to who is responsible to make integrated data systems that can really enable those responsible use of the data for ethical, equitable AI development. So I know you have another role on the National AI Research Resource in the past. And so think about how, as a community and as a society, can we improve those data ecosystems to enable those responsible development of the AI applications? So any comments that you may have about the data ecosystem?
That's a good question. He asked me, well, it was a good narrative. He said, do you have any comments? Offline. But I will say this. I do think that participatory design, I do think that starting with the scientific method, it is all in who is asking the question and what questions are being answered. And so if you thread trustworthy, responsible all the way through the scientific method, starting with the inquiry itself, I think is important. Right? So and here's the thing, a lot of times we run data sets, we get something out, we get an answer, but did that actually answer the question? Right? Was our objective function met? Right? And so, but the rest of it offline, for sure.
Now I'm really curious. I'm gonna have to follow up offline too.
Yeah.
Okay.
Hi, my name is Chelsea Menard. I'm a junior here at Morgan. I just wanted to know, what was your why in terms of exploring data within healthcare, because that's also a strong interest of mine. I know for me, I grew up in a clinical family, so I was just curious.
What a great question, young lady. Let's give it up for the student.
Amazing question.
I mean, that's an insightful question, right? Like, why was I interested in that data? I was interested in that data because I am standing here before you as a person that was intending to attend medical school and had the experience in primary education of having gone to a school that required that we have clinical rotations. Then I learned I couldn't be a medical doctor. I was like, this is too much, right, for me. And so I saw live birth at 16, right? And what shocked me about seeing it was this whole process. But what gained my interest was seeing the machines and the devices and the data and all of that going off. And ever since then, healthcare has been a through line for me, even in my undergraduate engineering studies, because we had a specialty option in industrial and systems engineering that focused on health systems. And so, and in industry, I worked in healthcare as well. So it's a through line for me. But it's also a through line for me because I think it is important from a family perspective, right? And so, again, we could talk about that more offline as well, because that could be a very long conversation. But I appreciate your question. You're welcome.
One more question here and then in the front.
Hello, my name is Dominique Page. I'm a senior here at Morgan State University, cloud computing major. So I really enjoyed your talk, and it personally stuck out to me because my own presentation, poster presentation today, targeted enhancing fairness in machine learning models.
Mm.
So your presentation, well, my question, I guess, is how can we make sure generative AI in healthcare works well for everyone, especially with underrepresented groups?
Okay, so it's a long process. One, I'm going to start with, and I don't like the term workforce, just personally, I don't, right? I'll say talent. It starts with a talent question, right? And so making sure that there are more persons, as you called it, that are underrepresented, that are involved in the process. Two, I think it is important to understand, is the data representative? And if it is not, then why are we using it? That's the question. And as the gentleman said, is there something else that could be used, or is there some integrative approach that can be used? And three, I think it is also important to interrogate what has been done prior. Right? So audit in AI machine learning is like a taboo. Like, no, everybody says, oh, it's proprietary. But there is some level of audit that is necessary. But the audit has to be independent, right? The IRS is not going to ask me to audit myself, right? So you don't ask, you need independence in that effort, right? So those were the three things quickly that I would suggest to you. You're welcome.
One more.
Thank you, Dr. Payton. It was a wonderful presentation. My name is Tamika Taylor. I'm mainly in the environmental sector, but I wanted to ask about resources that are underutilized or unavailable with the people of color, like that community, and how that sort of compares to the cost associated with treating them. Because from my thought is that the cost associated with treating the patients is higher for the lower economic or those demographics, right? The SES demographic. But then the availability of the resources or access to those resources, could it potentially be an offset there where we will be paying less if we were to encourage people to utilize the resources and cutting down on that, cost associated with treatment and things of that sort?
Sure, it's possible, but this is what I will say to you, and thank you for that question. What I will say to you is that, how can I say? I'm going to use Maslow's need hierarchy as an example. It's hard for me to get to the apex when my base is not set. So that means that what's my quality of food? What's my living? What's simple things could go a long way. And I've seen that in community. For instance, I've seen in community when you have put in walking trails, when you have made swimming accessible, when you have brought in quality food and not been in a food. So those kinds of things that may be small changes that may not take as many resources as one would think can go a very long way in terms of having, I want to say, preventative care as opposed to maintenance of care.